Your heart is responsible for providing oxygen and nutrients through the blood for your entire body. At the front end of the aorta, there is a flapper check valve called the aortic valve. The aortic valve opens so blood can flow out of the heart and into the aorta. It then closes to keep the blood it just pumped out from rushing back into the heart. As you age, or with different types of disease processes, the aortic valve can become hardened and stiffen. This keeps the flappers from opening completely. This is called aortic valve stenosis. As the valve becomes more stiff, the opening through which the heart must pump the blood through may become too small, causing the heart to strain. This leads to symptoms such as fatigue, shortness of breath, passing out spells, chest pressure or pain, and eventually death. Along with the traditional approach to aortic valve surgery, Missouri Heart Center offers an alternative that avoids opening the chest. This approach may benefit some select patients. TAVR is part of the comprehensive care that Missouri Heart Center provides Central Missouri residents.
TAVR, or transcatheter aortic valve replacement, is a less invasive procedure for patients that are considered poor candidates for open heart surgery. TAVR allows physicians to replace the aortic valve by inserting it over a catheter and placing the new valve within the diseased aortic valve. There are 3 approaches that can be used for TAVR: transfemoral, transapical, or transaortic.
The most common approach, 95% of the time, we're able to place the valve, which is mounted on a stent, through an artery starting in the groin, threaded up into the heart, and then deployed inside the patient's diseased valve, leaving the diseased valve in place. Alternative approaches are through the apex of the heart, which is more of an operation, or through other blood vessels such as an artery in the neck, the carotid artery, threaded down into the heart. All 3 of these approaches are possible. 95% of the time it can be placed through an artery in the groin. The valve is actually on a balloon. It's been compressed down to a small size, about 5 to 6 millimeters in diameter. It's threaded up through the blood vessel, pushed across the diseased valve, and the balloon is blown up, pushing the new valve into place. Valve leaflets have been sewn inside the stent. As soon as it's put into place, it starts functioning the way a natural valve works, which is as a one-way check valve.
In high-risk patients, TAVR or TAVR is safe or safer than surgery, but it's still an invasive procedure and there are associated complications, although they're rare. The most common complication is related to access, as we try to pass the stent and balloon into the iliac system or the leg arteries, trying to get to the heart. There can be some damage to those vessels, and those need to be addressed. You'll have a CAT scan done of your vessels before the TAVR is performed to make sure that we minimize those risks. In addition, there's a slightly higher risk of needing a pacemaker after TAVR than you would expect after surgical aortic valve replacement. This can range from 4 to 12% of patients. Once the TAVR stent is placed into the aorta, the crushing of the old calcium can push on the pacemaker structure of the heart, causing your heart to slow down. And as a result, you would need a pacemaker placed prior to being discharged. We monitor this throughout your hospitalization, and we put temporary wires at the time we're doing the procedure in case you do need a pacemaker at that time. In general, patients discharged from the hospital is not delayed by having a pacemaker after TAVR. Other risks, which are low risk, but they do exist, are stroke or injury to coronary arteries causing heart attack at the time, or bleeding from the aorta when the new stent is placed, crushing the old calcium out of the way. This can disrupt the aorta itself, the main artery, and that can lead to bleeding. We will spend a lot of time trying to prevent these complications and addressing them, and your doctor will discuss them with you to make sure that there's nothing any different that you would want to do during the time of the TAVR if a complication were to occur.
Generally, most patients are in the hospital for about 4 days, but it varies depending on what other comorbid conditions you might have or other diseases you might have. Everyone gets aspirin. and everyone will be put on Plavix for generally 6 months. You will see us after the procedure in about a month, and then depending on who your cardiologist is, you'll follow up with your cardiologist every 6 months after that. I do like to get an echocardiogram either in the hospital before you go home or during your first follow-up.
If you have aortic valve stenosis and would like more information, please contact your cardiologist.